Aloha guys, this is Dr. Tom coming back at you. Today we're going to talk about the function of the heart, which is a simple way of saying cardiac physiology. I'm going to try to get this on this one video, so we're going to move fast and loose. But we'll still cover what needs to be covered. Cardiac cycles, one heartbeat. Systole is when it contracts. Diastole is relaxation between them. You need to know that right now. Systole is contraction, diastole is relaxation. Period. I don't think we need to go in. Well, there's an atrial systole when the atria are contracting, and there's a ventricular systole when the ventricles are contracting. The atria beat together, and then the ventricles beat together. Systole is contraction. Remember that. Autonomic control of the heart. As you can imagine, there's quite a bit of it. Sorry, let me get this adjusted a little better here. Allows heart to respond to changing body needs. Involves sympathetic and parasympathetic or vagal nerves. Now, we covered this in anatomy some. Basically, parasympathetic involves the cranial nerve 10, the vagus nerve. Autonomic wiring. Sympathetics that involve the SA node, the AV node, the ventricular myocardium, or the muscle of the ventricles. Parasympathetics is the SA and AV node. So SA and AV have both sympathetic and parasympathetic innervation. The myocardial portion of the ventricles are all sympathetic. Firing of the sympathetic nervous system, or sympathetic system, increases SA node activity and heart rate. Why? It's the pacemaker. The SA node is the pacemaker. Increases speed of cardiac impulse through the conduction system. What does that do? Speeds up the rate that it's beating. And increases the force of myocardial contraction. So guys, there's the speed the heart's beating, but there's also how hard it contracts and how much blood it pumps every time it beats. Firing of the parasympathetics. Now remember, sympathetic charges you up, parasympathetics bring you down. So naturally, it decreases SA node activity and heart rate, decreases the speed of cardiac impulse from the SA to the AV node, but has no effect on strength of contraction. So the parasympathetic just slows it down. And how does it do it? Right here, by adjusting the conduction signal. Okay, cardiac output. How much blood is pumped every time the heart beats? Cardiac output is the amount of blood pumped by each ventricle in 1 minute. Now remember, the right ventricle is going to the lungs, left ventricle is going to systemic circulation. Cardiac output is the heart rate times the stroke volume. The cardiac output in the healthy heart can increase 4 to 5 times, like if you're having to sprint or you're doing some real, real demanding physical activity. It's called the cardiac reserve. Stroke volume is how much it puts out every time. I was going to see if they had that defined further, but maybe they will here. Yeah, here it is. Okay, heart rate is the number of times the heart beats each minute, caused by the SA node, the pacemaker. Makes sense. Stroke volume, the amount of blood pumped by the ventricle per beat. So the rate is how fast it beats. The stroke volume is whoosh, how much it's putting out. Cardiac output can be altered by changing heart rate and or stroke volume, either one, or both. How to change the stroke volume? Starling's law of the heart. Changes the force of contraction by stretching the myocardium. When you stretch the myocardial muscle, it strengthens the contraction. Mechanism that aligns the sarcomeres, remember those, for greater interaction between actin and myosin. Inotropic effect changes the force of contraction without stretching the myocardium. Mechanism makes calcium more available to the contractile proteins. Remember, guys, calcium is absolutely essential. Very interesting. So Starling's law, if you stretch it, it bounces back harder. Inotropic, it increases the force without stretching by making more calcium available. Starling's law, what goes in comes out. So if you have a high venous return coming in here through the vena cava, the ventricles stretch more, whoosh, they're going to pump harder. Or then in this case, it's the right ventricle. And then, it makes the left ventricle stretch more too, so it has a high cardiac output, as you were. If you have a decreased venous return coming back, then you have less stretching, so you have a decreased output, which is good because you got a smaller amount of blood coming in. Changing cardiac output. The CO can be increased 4 to 5 times the resting output. We've mentioned that a couple times now. Capacity to increase output above resting rate is the cardiac reserve divided by the resting rate, I suppose, is I guess what they mean. Clinical terms, end diastolic volume and preload. End diastolic volume, the amount of blood in the ventricle at the resting phase's end. In other words, how full the ventricle is just before it's ready to beat, and systole. This is also known as preload, another name for end diastolic volume. So basically, guys, the more blood that comes in and stretches the myocardium, the harder the ventricles are going to contract to pump the blood. Ejection fraction. Ejection fraction is the percentage of blood volume in the ventricle that is pumped by the heart. Ejection fraction is the percentage of blood volume in the ventricle that's pumped by the heart. Normal ejection fraction is about 67%. Exercise can increase the ejection fraction. In other words, someone that's in good shape, aerobically, cardiovascular speaking, their heart's more efficient. And of course, the other side of the coin is heart failure decreases. Heart failure decreases the ejection fraction. So someone with a weakened heart may not pump very much blood at all. Afterload. Afterload is resistance caused by blood pressure. So preload is how much blood's coming in. Afterload is how much blood pressure, or how high or low the blood pressure is. If you have high blood pressure, guys, the heart is having to work against that afterload, see? And that puts undue stress on it. That's one of the problems with hypertension. So afterload is resistance caused by blood pressure. If we have high blood pressure, it increases the afterload, makes the heart have to work harder. It also is hard on the kidneys too. More clinical terms. Inotropic effect, we mentioned that. Change in myocardial contraction, not caused by stretch. We mentioned that a moment ago. Chronotropic effect, change in heart rate. Guys, anytime you see chrono, that means rate or heart or time. Not heart, rate or time, like a chronometer or watch. Dromotropic effect, change in the speed at which the cardiac impulse travels from the SA node through the AV node and through the His-Purkinje system. So, very briefly, inotropic effect is a change in contraction, but not due to stretching of the myocardium. You might recall we mentioned calcium ions, actually. Chronotropic is a change in the heart rate, the pulse rate, how fast it's beating. Dromotropic is a change in the speed by varying how quickly the heart's conduction system works. Now, what I would do is just memorize these. Not too terribly difficult to do. Receptor language. SA node, AV node, myocardium activated by norepinephrine. We talked about that. Okay. Effects of beta-1 adrenergic receptors. Effect of activating chronotropic, dromotropic, or inotropic all increases it. Easy enough. The effect of blocking chronotropic, dromotropic, or inotropic has a negative effect on it. So it slows it. Okay. Guys, make sure you understand what these are. I mean, as long as you know the definitions, you'll be okay. But if you know that, you know, like if you speed up the heart rate, or if you're taking some sort of an adrenergic drug that has that effect, it's going to speed up the heart rate. If you block it, it's going to slow it down. So just know what dromotropic is, the speed that the signal comes down through the conduction system. Inotropic is the stretch with calcium, it's an increase in stroke volume without stretching. Muscarinic receptors, man, we talked a little bit about that in anatomy. SA node, AV node activated by acetylcholine, our old pal, the neurotransmitter. Effect of muscarinic receptors. Effect of activating lowers or it diminishes the chronotropic and the dromotropic, but if you block it, it increases both of them. Now that would have me fooled, guys, because I would think acetylcholine would always be something that would cause a positive if you activate it, but in fact it's just the opposite. Now, this is difficult stuff to understand, as my advice is just memorize what the terms mean so you can do well on a test if you get asked that. Okay. Now, this is real common. If we have heart failure, if we have left-sided heart failure, we're going to have stuff backing up into the lungs because it's coming from the lungs into the left side to be pumped out into systemic circulation. If the left side can't keep up with it, then you'll start having fluid backing up in the lungs. Backward, poor left ventricular function, left ventricular decreased blood flow to systemic circulation. Okay. So in other words, very quickly, if you have left-sided heart failure, you're not going to be getting much out into the body, but you're also not going to be able to handle the volume coming from the lungs. You're going to start having pulmonary edema, fluid build up in the lungs. Not good. Cyanotic because you're not oxygenated appropriately. Right-sided heart failure, think about it now. Where's it coming from? It's coming from the body into the right side of the heart, getting ready to go to the lungs. So you're going to have fluid back up into the body, especially the lower extremities. The ankles swell up, ankle edema, the liver, jugular vein. There's a lot of both of these guys out there, a lot of both of them. Backward blood blocks up in the veins, it drains blood to the heart. It's called CHF, congestive heart failure. Is real common, and one of the classic signs is edema of the ankles. And it's mushy. If you press on it, it takes a long time for that indentation to fade out. That's called pitting edema. Okay, heart failure treatment goals. Strengthen myocardial contractile force. Remove excess water. Why? We don't want to overburden the heart. Decrease the work of the heart. That's why they also put them on Lasix and other meds to get rid of that water retention. Protect the heart from excess sympathetic nerve activity. Why? We don't want to burden this already damaged organ by cranking it up. All right, we made it. I'm so proud. I know, guys, this muscarinic and nicotinic and all that is a little difficult. Go over the basics of it, know enough to try to. Starling's law, that's pretty simple. If you stretch it, it springs back and it pumps more. Doesn't beat up. Yeah, I guess it does beat harder. Okay. Systole and diastole are real important terms to know. Systole is contraction, diastole is relaxation. Hum, 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 hum. The atria and the ventricles both go through that, about every second or so. Remember now, guys, the atria beat together and the ventricles beat together. The atria beat first, force the blood through the valves down into the ventricles, then the ventricles beat. The right ventricle sends blood to the lungs. The left ventricle sends it to the systemic circulation. Pump, pump. What makes the lub-dub? The flapping of the valves closing. Lub-dub, lub-dub. We have autonomic control going to the heart at all times. Naturally, it's going to be sympathetic and parasympathetic fibers. The vagus nerves play a big role in that. The sympathetics affect the SA and AV nodes, naturally. We could guess that. And also the ventricular myocardium, the muscles of the ventricles. The parasympathetics, which kind of bring it down, affect the SA and AV node. So see how important this conduction system is, guys? It's what cranks everything up or back by how that signal is coming down through there. Remember that sympathetics have noradrenaline as the neurotransmitter. The vagus parasympathetics use acetylcholine. Firing of the sympathetic increases SA node heart activity and rate, increases speed of cardiac impulse through the conduction system, which is what we just were talking about. Increases the force of the myocardial and contraction. Firing of the parasympathetic system decreases SA node activity and heart rate, decreases speed of cardiac impulse from the SA down to the AV node, slows it all down, but has no effect on the strength of contraction. Why? Well, it doesn't. It's not involved with the myocardium, because is what I would say. Okay, we're finished up. Look over this stuff. Live it, be it. We'll see you next time. Dr. Tom signing off.